Let's go on to the next clinical situation. What do you do when asked to biopsy a new focal solid splenic lesion in a patient with a history of lymphoma? So the index case is shown below. As you can see on the contrast-enhanced CT scan, there's a oval-shaped lesion deep in the splenic parenchyma that was FDG avid on a PET scan and appeared solid and hypoechoic on the sonogram. So the options here are to refuse violently, refuse to biopsy it, but do so politely, agree to biopsy and schedule on a partner's day, or agree to a biopsy but only do fine needle aspirations, or agree to biopsy and do core needle biopsies. Well, so in this case, we agreed, as you can see, to go ahead and do a core needle biopsy, and this is a short clip of the biopsy taking place. This did turn out to be positive for recurrent lymphoma. After the biopsy, you can see that there's a small hemoperitoneum that developed in the perisplenic space. We followed this patient very closely, repeated scans a couple of times afterwards, and this never got any bigger. He never had any symptoms, and he was discharged from the hospital later that day. So let's just talk a little bit about splenic biopsies. We always are taught that the spleen is a very vascular organ and that we should avoid doing biopsies whenever possible. But this retrospective review that was published in this past year looked at 52 patients that were biopsied 62 times. They had a fairly even mix of malignant lesions and benign lesions. The results were that 24 of the aspirates showed a malignancy, 22 showed a benign lesion, and 6 were non-diagnostic. They used F&A approach with a range of needle sizes from 20 to 25 gauge in 37 instances, and core needle biopsies with a range of needle sizes from 19.5 to 14 in 25 patients. And of these biopsies, they had 2 episodes of hemorrhage. One was minor, probably similar to the case that I just showed you, and one, unfortunately, was severe and required a splenectomy for treatment. So, complications did occur, but they were uncommon. What about the accuracy? Well, the accuracy was actually quite good. Fine needle aspirations had an accuracy of 87%, and core needle biopsies had an accuracy of 92%. Now, in the specific instance that we talked about, lymphoma, this series had 22 cases, and the fine needle aspirates were adequate in 80%. Core needle biopsies were adequate in 100%. And I would recommend that if you have the situation where you're trying to diagnose recurrent lymphoma, that you do use core needle biopsies, because not only will that make the diagnosis of lymphoma, but it will help to characterize the subtype of lymphoma. Now, we mentioned that it is possible to biopsy both malignant and benign lesions. This is just an example of a benign lesion, sarcoidosis, that was diagnosed with fine needle aspiration of the spleen. Now, the last clinical scenario that I'm going to present to you is, what do you do when you identify a 1.5 centimeter solid extratesticular mass? This is the index case here, where we see a lesion that's just slightly bigger than a centimeter, superior to the upper pole of the right testis. This is a cine clip showing that the lesion is separate from the head of the epididymis as well. This was a transverse view. This is actually the head of the epididymis, and this is the lesion in question. You can see that it's quite mobile. It did not move from the superior aspect of the scrotum, but it was quite mobile. So what do? Do you call this a benign lesion and recommend nothing? Do you call it indeterminate and recommend serial clinical follow-up? Do you call it indeterminate and recommend ultrasound follow-up? Do you say it's indeterminate and recommend a percutaneous biopsy? or do you pull the trigger and call it potentially malignant and recommend excision? Well, let's just look at a few other lesions before we talk about that. Lesion in the upper left-hand corner is a solid, heterogeneous hypoechoic mass superior to the testis. This was resected and shown to represent sarcoidosis. Lesion in the upper right-hand corner is a similar appearing lesion but inferior to the testis in the region of the epididymal tail. This was also resected, shown to represent an adenomatoid tumor. The image in the lower left-hand corner just is included to remind you that there is the condition of polyorchidism, and extratesticular masses can sometimes be testicular tissue themselves. This is a case that Tom Winter loaned to me. Now this, on the other hand, is a lesion superior to the testis, large, solid, hypoechoic, slightly heterogeneous with an area of calcification. This looks a little bit more concerning than the other lesion that I showed you based on its size and sonographic morphology, and sure enough, this turned out to be a malignant leiomyosarcoma. This is a lesion that a patient that presented with a lesion just superior to the left testis. The lesion was primarily solid but had a prominent cystic component, readily detectable blood flow. This was an older gentleman, and we were concerned that this might represent metastatic disease. We actually looked around in other parts of his body and did find a large supraclavicular lymph node that had not been detected clinically, although it was palpable, as well as scattered peritoneal nodules. And this turned out to be metastasis from a lung cancer. So what's the data on solid extratesticular masses? There's actually a nice study that Mary Frates from the Brigham published in 1997. She looked at 19 surgically proven solid extratesticular masses. And surprisingly, or at least somewhat surprisingly, 3 of the 19 were malignant. All were sarcomas, a leiomyosarcoma, a liposarcoma, and a fibrosarcoma. 16 of the 19 lesions were benign, and you can see the list of lesions. There were 6 adenomatoid tumors, 2 lipomas, 2 epidermal inclusion cysts, 2 cases of sarcoid, and 4 miscellaneous other lesions. They looked closely for differences in the ultrasound findings in the malignant and benign lesions, and unfortunately, there weren't characteristic differences in either the appearance, the size, or the location of the lesion. Now clearly there's a selection bias to this type of a study because many benign lesions were probably not resected and did not get included in these statistics. However, many of the benign lesions that are extratesticular, in fact the majority, are lesions that are clearly benign and you wouldn't even consider resecting. And in that list you include things like spermatoceles and hydroceles and varicoceles. Those are so easy to diagnose you wouldn't even think about doing surgery on those. So the lesions that we're really focusing on are the other lesions, the solid extratesticular lesions, that have a slightly different differential diagnosis. So in this case, our index case, this turned out to be a papillary cystadenoma of the appendix testis. And it was so pedunculated that explained the rotational component when we compressed it. Well, that concludes this lecture on what do you do when. Thank you very much for your attention.